So next I would like to introduce my next speaker, Dr. Anand Balasubramaniam. He's a senior consultant at Shankara Eye Hospital, Bangalore, and taking care of cornea department over there. Next to you, sir.
Good morning, everybody. At the outset, I'd like to thank the AIOs as well as Dr. Malik for giving me an opportunity. Now, after these two talks, I would be playing the devil here by talking about complications of cross-linking. I'm just going to skip all these slides because all this has already been shown. Now, we have already known that from its inception in 2003 onwards, for the past 20 years, it has transformed and it has gone through a lot of changes and has now become the global standard of care for treating various ectatic conditions. It is safe for children as well as adults, but still there can be a certain list of complications and unexpected response following C3R. Now, you can have a direct complication because of the incorrect technique or the wrong patient inclusion, or it can lead to indirect or secondary complications, secondary to the BCL that we use, the patient poor hygiene, and any undiagnosed ocular surface disease that has been there prior to the C3R. Now, it can also be because of the improper UVA exposure, because of the altered wound healing response, and because of changes in the epithelial removal following the cross-linking. Now, the complication can be early when it is within 3 months after cross-linking, or it can be late after 3 months of cross-linking. Now, the list includes it includes incomplete or delayed epithelial healing. They can be sterile infiltrates, both peripheral as well as central. You can have infectious keratitis, mainly reactivation of the viral infection or bacterial. There can be corneal edema or endothelial dysfunction, or even very rarely corneal melt. The late complications include biomechanical failure in the form of excessive corneal flattening or vision impairment in the form of late onset corneal haze with scarring. But yeah. So the first one, the delayed epithelial healing. Now, as we all know, it is a very critical step because it helps in the penetration of the riboflavin or the epi-off technique. There are transepithelial cross-linking also being done to avoid this step, but efficacy-wise, studies have shown that there is a marked difference in the efficacy between the two. Normally, the epithelium heals within 3 to 5 days. If it doesn't heal within 5 days, then it is a delayed epithelial healing. Now, the reasons being, it can be because of the chemokines and the cytokines which are released from the epithelial cells, which are pro-inflammatory, which prevents the epithelialization. It can also be related to the BCL mismatch between the corneal curvature and the BCL. As we all know, the BCL comes only with 2-3 standard fits. So if in a very steep cornea, there might be a mismatch, and that can continuously abrade the epithelium at the steepest point. The use of NSAIDs and steroids also can result in delayed healing because of the MMP release. Very rarely there can be a differential limbal stem cell damage, especially in the superior and inferior. Very few studies have shown that there is a very basic impact on the limbal stem cells following the C3R. So patients who have undergone C3R should be carefully observed till the epithelium is completely healed because it can predispose to infectious keratitis. Now, coming to sterile infiltrates, it has been reported up to 7.6% of the cases. It normally comes between 24 to 48 hours, and it is mostly in the periphery as compared to the center, though center also it can come. That is because of the mediated immunity to the staphylococcal antigen from the ocular surface and the lid margin, which can be deposited at high concentration in static pooling areas, especially around the BCL in the periphery. Patients who have not been treated well prior to especially VKC patients have not been treated well before the cross-linking, advanced keratoconus, patients with blepharitis and thin corneas are predisposed to sterile infiltrates. If it occurs, we have to give high-dose topical steroids depending on the stage or the severity of the infiltrates. And if not treated properly, it can lead to peripheral thinning and in very rarely perforation. So it is very important to refrain from leaving heaped up epithelium, especially at the margin, before placing the BCL. Now coming to infectious keratitis, the presence of epithelial defect, use of bandage contact lens, and topical steroids in the immediate post-op period are risk factors. The overall incidence is very, very less because CXL nowadays is being used even for infectious keratitis. And and there's a study by Tamilis who clearly showed that the infections tripled when the patients were put on BCL and topical steroids in the immediate post-operative. Now, this normally occurs between 2 to 6 days after the procedure. Studies have shown that 50% of them are bacterial, out of which 30% are gram-positive and gram-negative. Very rarely, there can be a reactivation of the previous viral infection because of the UVA radiation, post-op use of steroids, and because of the release of inflammatory cytokine. So the picture on top was my own patient who had a very severe infection. Scraping had shown gram-positive cocci. We treated with vancomycin and moxifloxacin, and subsequently after 3 to 4 months, it completely scarred. The one picture below is a reactivation of the previous viral infection, where we can see dendritic pattern. Now, there are also been reported CTK following cross-linking, which is very similar to that seen in LASIK, where there is a central or a paracentral non-inflammatory opacity. There can be presence of striae and flattening, which can cause a hyperopic shift. Now, the reason is unknown, but they have postulated to be because of the surgical glove components, secretions from the memobrane gland, or it can even be because of the marker pen or the povidone-iodine. Very rarely, there can be stromal loss in CTK because of the keratocystic apoptosis. Now, endothelial related, it is very, very less in literature. The permissible, irradiation at the endothelium is around 0.35 milliwatt per centimeter square, but because of the good absorptive property of the riboflavin, it is only 0.18, which is very, very safe for the endothelium, but still it can occur, and normally it presents during the first 1 week post-operatively. And Gokhale in his study has shown very clearly that in the immediate post-op, there is as much as 40% lower endothelial cells as compared to the fellow unoperated eye. Now, it can be because of the riboflavin solution, or it can be because of the improper calibration on the positioning of the cross-link device, as it was very clearly mentioned by Dr. Ankit in the previous talk. It can lead to epithelial and stromal edema, which is diffuse, accompanied by DM folds, and in very, very severe cases, it can even lead to decompensation. Coming to corneal haze can be early onset and late onset. The early onset mild haze is generally seen in almost all the patients, and it is also considered as a surrogate marker for the efficacy of the cross-linking. Now, very rarely beyond grade 2, it's around 9.3%. It is very important to differentiate between the haze of PRK and C3R, wherein in PRK it is much more superficial, whereas in C3R it is slightly more deeper, somewhere in the 200 to 300 micron range. The reason being because of the repopulation of the activated keratocytes and the reorganization of the collagen fibers, which can affect the light backscatter and the corneal transparency. Now, most of the times it is self-limiting, which peaks at 1 month, and then there's a gradual reduction between 3 to 6 months, and 6 months, most of the times after 6 months it clears off. In very symptomatic cases, we can give an intense course of topical steroids. Now, the late onset haze is anywhere between 8.6 to 12%. The risk factors include advanced keratoconus, Vogt striae, then keratometry more than 70 diopters, and a thin cornea less than 420. Very rarely, in very advanced haze, it can cause a reduction in the BCVA and increase in the hydroid aberrations. Now, coming to the biomechanical failure, one diopter flattening is something that all of us desire following the C3R procedure, and we know for sure that it improves the best corrected visual acuity as it flattens the cone, and sometimes it also helps in the contact lens fit also. But what happens is sometimes is because of reasons unknown, this flattening can progress where there can be a hyperopic shift, and there can be visual deterioration. Now, various studies have shown that corneal flattening greater than 5 diopter is considered as a progressive flattening. Now, several studies have shown that a preoperative Kmax more than 55 diopters is considered as a risk factor for corneal flattening more than 2 diopters within the first year of surgery. The other risk factors include age and stage. So younger the age, it is postulated that more the flattening can occur, and also the stage. So more advanced the stage, more the flattening that can occur. They also have shown that patients who underwent a cross-linking procedure, over time also, there can be a progressive flattening as late as 12 years post-op also. Now, just two pictures depicting the pre-op picture as well as the progressive flattening that is seen over time. Now, coming to keratoconus progression, which is the last, the progression can occur in around 0.08 to 33% of the patients. It is more seen in the epion as compared to the transepithelial, and it is defined as a Kmax increase of more than 1 diopter within 1 year, or a loss of BCA of at least 2 lines. Now, Collar in his studies has shown that a patient who has a pre-op Kmax 58 would reduce the incidence of failure in around 1/3 of the patients. Habitual eye rubbing, as well as patients who are predisposed to allergy in the form of atopic patients, and hormonal imbalances are other risk factors. Now, extreme corneal thinning and eccentrically located cone has also become additional risk factor for progression. It is also very important to differentiate a pseudoprogression, especially in patients who are contact lens warpage and epitel hyperplasia. So if a patient has undergone a cross-linking and is regularly wearing contact lenses, especially RGPs or rose-scale lenses, it has to be stopped 1 week prior or 2 weeks prior before you do a repeat topography. And if you are suspecting epitel hyperplasia, then we have to do an epitel mapping or a advanced ASOCT mapping. This is just a picture showing you the increase in the keratometry in the topography. To conclude, complications from cross-linking can occur and warrant caution when considering treatment for all individuals with proper patient selection. Early and prompt diagnosis and treatment can prevent vision-threatening sequelae, and it is very important to have a follow-up of these patients because they can be late complications as much as 10 years post-C3R. So please don't take this procedure lightly, because every procedure has its own set of complications which you have to keep in mind. Thank you.
Thank you, Dr. Anand. That was a wonderful talk. Any questions for Dr. Anand? Any doubts or any questions?